Live.
So good morning once again. Welcome back to the e-master classes on nephrology. We welcome Dr. Uma, who will be the speaker today, and Dr. Pankaj Garg, past President IIP Delhi. And I also welcome Dr. Neha Bhandari, who has been coordinating these sessions very nicely and making the whole module very interesting. And we welcome senior nephrologist Dr. Amit Agarwal, who is working as senior consultant in Batra Hospital. I welcome Dr. Dinesh, our secretary. I request Dr. Dinesh to please say a few words.
Good morning, sir. Good morning. Sorry for little late, actually. And on the behalf of IIP Delhi office, I welcome you all. And this is after a pause of 2 weeks, after a successful conference of Pediatric Conference of North India 2026. We thank all delegates, all faculty in PCNI. And again, we are joining in masterclass nephro session. And today is the nephrotic syndrome. And chairperson for that is Dr. Puneet Kumar Sharma. Expert is Dr. Amit Agarwal. And many congratulations to the Dr. Neha Bhandari ma'am. And the today's speaker is Dr. Uma Ali. So pass on to Dr. Ajay Gupta to say a few word welcome address, followed by Dr. Neha Bhandari, and then we'll start the session.
Thank
Pass
you,
on to
Dr.
Dr. Ajay,
Dinesh.
sir.
Thank you,
Yes, sir.
Dr. Dinesh. As we have already got a very enthusiastic response for the e-nephrology module, we'll be starting with the hematology for pediatricians module next, immediately after this module is over. And I request all of you to please register for that also. We'll be sharing the link. And I request our past president, Dr. Pankaj Garg, to say a few words. And then I request Dr. Neha to please take over.
So, good morning, everybody. And
Welcome Dr. Puneet Sharma, the chairperson for the day. And I also request him after Dr. Pankaj to say a few words.
so, first of all, a big clap to Dr. Ajay and Dr. Dinesh for a very successful and academically enriching PAT Conference of North India, the annual conference of IIP Delhi, attended by 700 registration, 2 halls, 2 days, good show, good lunches and dinner, and good social networking. So, great work, Dr. Ajay and Dr. Dinesh, and the whole team, amazing team of PC9, Dr. Puneet, everybody, who has done a great job. So IIP Delhi has always been at the forefront of academic activities throughout the year. So as you can see, that throughout the year from 1st January onwards, there's some or more activities going on. E-Masterclass is one of the very nice initiative of IIP Delhi, which is going on for last 4 years now. And nephrology is again a very, very important masterclass which is being held. So congratulations to the whole team, especially to Dr. Neha, who has niched a very, very interesting sessions. All the good speakers have been enrolled and they're doing a great job. So thank you so much, Dr. Neha. All the speakers, Dr. Uma, Dr. Amit, with the help of all the academicians, we're able to do a good academic activity. And back to Dr. Ajay for his words. Thank you so much.
Thank you, Dr. Pankaj. I request Dr. Puneet Sharma sir to say a few words.
Morning, everyone. It's indeed a pleasure to be at this platform. And this e-certificate course is very much in demand. Whatever IAP Delhi is doing, all kudos goes to the team IAP Delhi, Dr. Ajay, President, Dr. Goyal, as Secretary, and even past President Dr. Pankaj has done a lot. They have done a tremendous work in this field. So this time we are dealing with the different altogether topics like pediatric nephrology. We have taken up. So today's topic is nephrotic syndrome approach and management, and our esteemed speakers, Dr. Uma Ali. She is a senior pediatric nephrologist at Lilavati Hospital, SRCC Children's Hospital, Jupiter Hospital, Vijayawada, and Hospital for Children. So with her, Dr. Amit Agarwal, a dear friend of us, she consultant pediatric nephrologist at Batra Hospital Medical Research Center. So I welcome you all for this important topic that we face in every day in our OPD. Uh, Thank you very much. Over to speakers.
Pass on to Dr. Neha, ma'am. Yes.
Thank you, sir. Thank you, IIP Delhi, Dr. Ajay and Dr. Dinesh, Dr. Pankaj, sir. Big congratulations for the wonderful conference. It was so amazing to see all halls were jam packed. And coming back to nephrotic syndrome, why we are having a second class on nephrotic syndrome, as everybody says that this is the most common thing that we always see in our pediatric OPDs, and sometimes we really don't want a child to be not treated well. So most of the time the basic management, which includes edema management, lot of times you see hypertension in them. So what we are planning to cover is the basic approach and management by none other than Dr. Uma Ali. So she is a known faculty for pediatric nephrologist all over India. So I would not waste too much time and would welcome our expert Dr. Amit Agarwal as well as Dr. Uma ma'am, who is the speaker. So ma'am, everybody is eagerly waiting for the session. We'll just take it to you.
Good morning, everyone. Thank you, Neha. Thank you, IAP Delhi, for inviting me. So we'll begin right away. Nephrotic syndrome is one of the commonest conditions in pediatric nephrology that we all encounter. Very easy to diagnose, but can be very challenging to manage because it runs a long course. And we all know the definition. It's very easy to diagnose. The face is a spot diagnosis. There's generalized anasarca, massive proteinuria, which is defined quantitatively as 40 milligrams per meter squared per hour, or easier, 50 milligrams per kg per 24 hours, along with hypoalbuminemia, less than 2.5 grams per dl of serum albumin, and hyperlipidemia, more than 200 milligram per dl of cholesterol. So just these four components define nephrotic syndrome. So an easy diagnosis to me. Now, just briefly, why does nephrotic syndrome occur? We don't know the real cause why it happens in children, but what does happen is an injury to the podocyte. The podocyte are the foot processes, which are giant visceral epithelial cells with projections, which are called foot processes, which rest on the glomerular basement membrane of the capillary endothelium. So these foot processes get damaged. They are the barrier which prevent leakage of proteins. They allow urine and other solutes to pass by, but hold back larger macromolecules. So when the podocyte is damaged, you may get leak of proteins into the urine. So this is how the urine is formed, and there may be leak of proteins. And this injury can occur commonly due to immunological problems, which are not that clearly defined. But there is T cell dysregulation, which has been known for a long time. And now increasingly we recognize that there may also be B cell dysregulation. The other is it may not be immunologically mediated, but there may be genetically deficient podocyte proteins. So the podocyte integrity is compromised from birth because lack of these proteins weakens the skeleton of the podocyte. So there are many, this is just a diagrammatic representation. This is the basement membrane. These are the inner endothelial cells of the capillary, the yellow ones. And here these big blue cells are the visceral epithelial cells. And you can see there are many proteins along the way in the podocytes, which serve different functions to stabilize the podocyte and keep it intact. So any deficiency or absence of these proteins, which may occur because of a genetic mutation of the gene that produces these proteins, can compromise podocyte integrity to a variable extent and lead to protein loss. So these are our normal podocytes and foot processes, interdigitating processes. And this is when the podocytes get flattened. So it is lying now as a flat foot process, effaced podocyte. So what happens because of this? That proteins which should not normally leak into the urine are leaking in a large amount, so a massive proteinuria, which leads to low serum albumin, hypoalbuminemia, that leads to low oncotic pressure. Because the oncotic pressure is low, water seeps out from the plasma compartment to the tissue spaces and you get edema. Despite increase in total body water and edema, the plasma compartment may be contracted, and so that stimulates renin-angiotensin to cause salt and water retention. So you have more retention of salt and water, but because of the pathophysiology, we are unable to keep this in the plasma compartment, and this also moves out into the interstitial spaces, causing more edema. So it becomes a vicious cycle where the compensatory mechanisms add to the edema instead of reducing it. The low oncotic pressure increase the synthesis of lipoproteins and other coagulants by the liver in the process of the liver trying to produce all kinds of proteins to compensate. And so you get hyperlipidemia. And we only measure albumin, but there are loss of many other proteins. Transferrin, so you have some degree of anemia. Antithrombin 3, so you get a tendency to thrombosis. Properdine, factor B, which are complement proteins, so you lose the capacity to defend against encapsulated organisms. And so you're prone to infections by organisms like pneumococcus, etc., which are encapsulated organisms. So you get many complications are based on this pathophysiology. You have massive edema with ascites, hydrothorax, many times scrotal edema. And this may even cause skin breakdown, which is a worrying condition. There may be hypovolemia despite massive edema, proneness to infections because of multiple factors, some of which we mentioned. So one of the unique infections for nephrotic is a spontaneous bacterial peritonitis. And you may have thrombotic complications, a little rarer but quite serious because of multiple factors. There's hemoconcentration, there's thrombocytosis, hyperlipidemia, increased procoagulant synthesis, loss of AT3, and our use of diuretics, which may increase hemoconcentration. So these are some of the common life-threatening complications that we encounter. So let's go through a case. This is a 3-year-old child with puffiness of face, edema feet, decreased urine output since 2 weeks. She's 15 kg, 90 centimeters. Both height and weight are okay for age. Blood pressure is 100/60 and the chest is clear. So the first thing we need to do is take a history and clinical examination to rule out infections. And second, is there any systemic disorder presenting as a nephrotic syndrome? So do you have something like lupus, Enoch-Schondlin? So skin, joints, liver, spleen, nodes, anemia, these are some of the important things to look out for as markers of the presence of systemic disorders. Another thing we look out for is, are there any atypical features? Now, what do we mean by atypical features? Features that may, at the beginning, tell us that this may not be a minimal change nephrotic syndrome. As all of you know, minimal change nephrotic syndrome, which means hardly any change on light microscopy when you do a biopsy, and which has the best prognosis for nephrotic syndrome, is the most common variety of histopathology you see in nephrotic syndrome, and has typical features of starting between 2 to 7 years. So if you have age of onset below 1 year or above 7 years, gross hematuria, raised creatinine, or low serum complement, then these are not features of minimal change nephrotic syndrome. So you're likely to have either a complication in the nephrotic syndrome or this is not a minimal change. So right in the onset, you get warned that you may be dealing with something more. Now, this child's report urine routine showed an albumin 3 plus and occasional granular CARs. The urine protein creatinine ratio, which is the commonest test we use in children for quantitating urine proteins, was 4.2. In normally, the normal ratio is 0.2. So it's a very low amount of protein in the urine. Anything above 2 milligram per milligram tells us that there is nephrotic range of protein. The BUN is 15, creatinine is 0.4, which appears normal. Serum albumin is low, 2.2. Cholesterol is high, 350. So very clearly, this child has a nephrotic syndrome. Additionally, we'll do a Mantoux test. Since it's the first time we are seeing the child, we want to exclude tuberculosis, and an X-ray chest to just rule out TB. So then the question comes, what all do we need to start? Should we start prednisolone 10 milligrams 3 times? Should we add diuretics? Should we add H2 blockers? Should we add antacids? Many times all these are started at one time. Now let's see what the ISBN guidelines say. That's the Indian Society of Pediatric Nephrology. This recommendation is to give prednisolone at 2 mg per kg per day. That's your starting dose. Diuretics are avoided unless you have very significant edema. Treatment with steroids will itself lead to diuresis in 5 to 10 days in a steroid-responsive patient. And antacid and H2 antagonists, etc., not needed unless there is upper GI discomfort. Usually the advice should always be to give prednisolone after milk or after breakfast and not on an empty stomach. So that itself becomes gastroprotective. The 5 Ds that are important and which get missed out is to explain about diet to the parents, that they need to give normal calories. They need to give normal, good amount of proteins, but not excessive proteins. So roughly 1.5 to 2 grams per kg proteins. And 30% of calories from fats. So generally what we advise is not a total salt-free diet, as that is very unpalatable and the child may totally stop eating, but to avoid added salt and foods which contain high salt. So no sprinkling salt on table, no pickles, papad, wafers, commercial foods, packed items, etc. And no deep fried foods. We try to reduce butter and cheese, egg yolk, because they are common sources of cholesterol. And proteins according to the child's diet, whether they are vegetarians, non-vegetarians. Non-vegetarians, egg white is a good source of protein. For vegetarians, milk is a good source. We need to also teach them the use of dipstick. Okay. So that they can monitor the urine proteins at home. That helps them and also helps us when they come to see how the child has been faring. To keep a diary where they note down their dipstick findings, whatever prednisolone dose they are receiving, and if the child has had any infection at any time. So a daily notes, just mentioning 3 things would be good. Important is to determine when they should visit next, doctor's visit, and advise them not to take oral polio vaccine, because that's sometimes given without our knowledge. And it's a live virus and should be avoided when there is high dose steroids going on. Now, following up this child 4 weeks later, there's no edema. Urine albumin is negative for 3 consecutive days, which is our definition of remission. That urine albumin negative or trace for 3 consecutive days means, and this should preferably be in the first morning sample, so that you get the most concentrated urine of the day. So the guidelines tell us that how long we should treat. Initial episode should be treated with oral prednisolone daily 2 milligrams per kg for 6 weeks. This can be given as a single oral dose or it can be given as divided dose. And after 6 weeks, we give 1.5 mg per kg, again as a single morning dose on alternate day for next 6 weeks. So the total duration of treatment is 12 weeks, 6 weeks daily, 6 weeks alternate day. And this particular regime, which is a German regime, has been now followed in most parts of the world because it has been shown to reduce the incidence of subsequent relapses in the following 2 years. Now, BP should be maintained below the 90th centile, and you can add antihypertensives if the blood pressure is high. Always check it against the table. We would use the American Academy of Pediatrics 2017 tables, where you can check it against the age and height of the child, gender. And you can add either ACE inhibitors or calcium channel blockers for the management of hypertension. Now, at 12 weeks, the child is now on alternate day steroids. He's reached the end of his therapy. BP is normal. And because we're tapering off the steroids and BP is okay, the antihypertensives are gradually tapered and omitted, and steroids are omitted after a total of 12 weeks, 6 weeks of alternate day. Okay. Now, it's important to remember this point to find out if they've received pneumococcal vaccine, and if not, to give pneumococcal conjugate vaccine after 2 weeks of steroid omission. So all children with nephrotic syndrome should receive pneumococcal vaccine. If they are 2 to 5 years, there are 2 doses, conjugate vaccine first dose and 23-valent polysaccharide vaccine after 8 weeks. Now, what happens to this child further? After 4 weeks of steroid omission, the child comes with fever, vomiting, abdominal pain, puffiness, oliguria. And a cytic tap is done, which shows 125 cells and 70% polyps. And the urine albumin is 3+. So now becomes the dilemma, what should we be doing? Is this peritonitis? Because of the obvious relapse, there's urine albumin 3+, puffiness, oliguria. Should we restart steroids or should we treat the infection first? So this is often a stage of question mark which we have. Now, may we diagnose peritonitis whenever there is more than 100 WBCs in the ascitic tap, of which more than 50% are neutrophils. So this child fits into that. He had 125 cells, 70% neutrophils. We should treat infection before steroid therapy, because steroids may make the treatment of infection more challenging and would mask the signs of worsening infection. Most common organism is a strep pneumoniae, but others like E. coli, etc., also can be causes of peritonitis. But important to remember that some of these children will require stress doses of steroids. So we are not giving steroids for the nephrotic syndrome, but to prevent adrenal crisis, because they've received steroids earlier, so the pituitary adrenal axis will be suppressed and may not be able to mount endogenous steroids enough for stress. So those who have received high-dose steroids for more than 15 days in the past year, it's now become a full year, anytime in the last year, should, in the presence of a severe infection, receive stress doses of steroids to cover that period. So we know that peritonitis comes from a combination of factors. There's ascites, which becomes a good medium for bacterial growth, loss of immunoglobulins and complement proteins in the urine, and impairment of T cell function. And many times we are also using immunosuppressive drugs, which further reduces immunity. So this child was given IV ceftriaxone. The duration of treatment is 7 to 10 days. A stress dose of hydrocortisone, that is 2 mg per kg, not prednisolone. This is hydrocortisone dose for 3 to 4 days till there's stabilization and the infection is under control. Then you can taper and omit. But after treatment of infection, after 10 days, the urine albumin is still 3+. So this child has a relapse, which we define as urine albumin 3+, 2+ or more on 3 consecutive days. Now, again, so the treatment of relapse is the same dose as your original treatment, 2 milligram per kg per day. But you don't have to give it for 6 weeks. You have to give it till the child achieves remission. So after 7 days, the child's urine albumin was negative. So if you watch for 3 consecutive days and it's negative for 3 days, you can consider it as remission. And the prednisolone can be shifted to alternate day given for 4 weeks and omitted. So the relapse treatment is a shorter treatment. Okay, you give the daily dose till you achieve remission and alternate day dose for 4 weeks. So longer therapy is not required for infrequent relapses. Now, this child had 2 more relapses in the next 4 months. That means totally he's had like 3 relapses in the 6 months following his first attack. And relapse, we said, we define as urine albumin 2+ or more on 3 consecutive days. And a frequent relapse is somebody who has 3 or more relapses within 6 months after treating the first attack, or in 4 attacks in 1 year. So now remission has been induced with prednisolone at 2 mg per kg. Now, what should we do? This is not an infrequent relapser. So it may not, in infrequent relapses, we would have stopped after 4 weeks. So here, what is our question? Should we continue steroids on a tapering dose for longer duration? And we have a number of second-line drugs like levamisole, cyclophosphamide, cyclosporin, tacrolimus, mycophenolate, etc. Should we be adding one of these, and if so, which one? So the general initial management of frequently relapsing would be not to stop the alternate day at 4 weeks once you diagnose them as frequently relapsing, but taper the dose on a weekly or 2-weekly basis gradually and maintain on a dose of 0.5 to 0.7 milligram per kg on alternate day for maybe at least 9 months. You can, if there is no steroid toxicity and child is doing well, can keep it for a little longer, but 9 months to 1 year, one can try this. Now, this child was continued on alternate day steroids, but he needed 15 mg alternate day, which comes to close to 1 mg per kg for him. Should we be giving calcium? Should we be giving vitamin D? So if steroid use is more than 3 months, then we should be giving calcium supplements and vitamin D supplements, because steroids does affect bone mineralization, and we do need these supplements when we are on long-term steroids. So now we're looking at almost 10 months after initial presentation. He is maintaining remission, but on a fairly high dose, 15 mg alternate day, which comes to close to 1 mg per kg for him. This is important to see the dose, because the steroid toxicity is fairly dose dependent. So we generally believe that if you're using less than 0.5 mg per kg on alternate day, probably you have a minimized the problems of steroid toxicity, and this can be tolerated for a longer period. But anything above that, the child is at risk for some steroid toxicity or the other. And if he taper, he relapses. He's also Cushingoid. His BP at the moment is okay. His weight is 17 kgs. Height is 91 centimeters. We have examined his eyes. There are no cataracts, no raised intraocular pressure. So on face value, he looks okay. He's taking a higher dose, but he's okay. Should we continue, not continue this? Should we add another drug? But if we look carefully, his height is only 91 centimeters. So it was 90 centimeters when we started. 10 months down the line, he's hardly gained any height. So he is not without steroid toxicity. He's got a statural retardation. His height velocity is not there. It's diminished greatly. And so he is manifesting steroid side effect. So very important to look at your height velocity because that's often a missed parameter, and assume that child's not having any steroid toxicity when he is actually having effect on height. So now the question comes, should we have a renal biopsy and which second line drug should we add, levamisole, cyclophosphamide, cyclosporin, etc. Now, one thing that is very clear is we do not need a renal biopsy for a frequently relapsing steroid-dependent nephrotic syndrome because the primary response is one of steroid sensitive. You give a full dose, they will respond, which indicates that the underlying histopathology is probably minimal change only. And so you may not get any additional information by biopsying a steroid responsive child. But what we do need to do is a careful evaluation for steroid toxicity once in 6 months in all those who are taking steroids long term for nephrotic or other diseases. And some of the things I didn't include, but which need to be seen, is your blood sugar, HbA1c. You need to see the BMI for obesity and proximal myopathy, difficulty in climbing stairs, getting up from sitting position on the floor, and also any behavioral adverse effects which some children do show. Now, there are no hard and fast rules of which drug you should now use as a second line. So we will just say when we are more likely to use one drug than the other. Now, levamisole has a moderate steroid-sparing effect and relatively very few side effects, has been widely used in India, and not many major side effects are reported, though it can have neutropenia and vomiting, skin rashes, and sometimes ANCA-positive vasculitis, which is a very rare side effect. Cyclophosphamide is usually reserved because it's a more stronger drug with a bigger profile of side effects. For severely relapsing nephrotic syndrome, who are steroid dependent on very high dose, who are steroid toxic, who have limited compliance because it's a finite course, and who have had complicated relapses. That means a relapse that has been difficult to control and has been complicated by the other complications of infection, thrombosis, hypovolemia, etc. And cyclosporin A is a third alternative, or tacrolimus, depending on your choice and age of the child, for frequently relapsing or steroid dependent, usually despite above medications. The issue with cyclosporin and tacrolimus is you need to give them for a long time. They are not a short course. And you need to give at least for a year and often 2 years. So the choice, as I said, if there's not much steroid toxicity and not a very highly dependent on high dose of steroids, levamisole would be a first choice. If they are steroid dependent, requiring more than 0.5 mg per kg, showing steroid toxicity, having complicated relapses, then maybe you need a stronger drug like cyclophosphamide. When we use cyclophosphamide, we use it in a dose of 2.5 mg per kg per day. And we need to do CBC every 2 weeks. And this child's count dropped from 9,000 to 4,500. So should we stop cyclophosphamide? So if it falls below 4,000, you need to temporarily discontinue cyclophosphamide and then restart after the counts recover, which usually the counts do recover within 1 to 2 weeks. Other important thing is the tablet should be taken in the morning. Water intake should be very good because you have a risk of hemorrhagic cystitis, and they should void frequently. So bone marrow suppression is a problem. So blood counts every 15 days, alopecia, hemorrhagic cystitis, and long-term effects, which is why we are cautious about using cyclophosphamide, is the possibility of gonadal toxicity. So to limit that chance, the total cumulative dose you're giving for the entire course should not exceed 168 mg per kg. So if you're giving for 8 weeks, the combined added up dose divided by the body weight. And there is a future risk of malignancies, which is not dose dependent. We also avoid using cyclophosphamide in the pubertal age group because children during puberty are more prone to the gonadal toxicity of cyclophosphamide, and we do have other drugs which we can use. And when should the child consult a pediatric nephrologist? When he or she has been steroid dependent for more than 6 months, there's clear evidence of steroid toxicity, you're considering starting a stronger drug like cyclophosphamide or cyclosporin, or it has already been used as steroid dependent or FRNS despite cyclophosphamide, and if there's a complicated relapse. So these are times broadly when you would need the help of a pediatric nephrologist to help you tide over this child in a sane way. So Neha, do we have time to go through a second case, or should we stop at this?
Ma'am, we'll finish in 10 minutes.
Yeah.
Sure, ma'am.
Yeah.
We'll do.
Okay. Okay. So this is a slightly different progress of a child. A 2-year-old child with 10 kg with nephrotic syndrome. Clinical presentation is fairly similar. Urine albumin 4+, albumin creatinine 5.6. BUN creatinine normal, serum albumin quite low, 1.3, cholesterol 380. And the child is started on 2 mg per kg of prednisolone and divided doses. Now, at the end of 4 weeks, the child still has albumin 3+, although there's no edema. So is this child steroid resistant? Can we decide at this stage, or should you continue steroids for 2 more weeks before deciding? So there have been different definitions of steroid resistant nephrotic syndrome, 4 weeks, 6 weeks. Some people take 8 weeks, but the most common definition which we are now using in India is if there's no response after your 6 weeks of daily steroids. And when we say no response, it means urine protein response. The urine albumin should become negative or trace on 3 consecutive days. If that has not happened within 6 weeks of daily steroids, this child is steroid resistant. And this is a very important diagnosis to make because it changes the entire trajectory and prognosis for the child. The steroid-resistant nephrotic syndrome may account for 10 to 20% of all nephrotics. 50% fail to respond to other immunosuppressants. That is your worry. And the risk of progression to end-stage kidney disease is 30 to 60% at 10 years and accounts for almost 20% of all end-stage kidney diseases in children and adolescents. Now, does this child need a biopsy? Very much so. All steroid-resistant nephrotics should undergo renal biopsy. We must do light microscopy and immunofluorescence in all cases. Electron microscopy optional if available. Now, the possibilities which we may have on renal biopsies a minimal change nephrotic syndrome, even though the child is steroid resistant, or a focal segmental glomerulosclerosis. These are the 2 common entities we tend to find in the background of a nephrotic syndrome, and we call them idiopathic nephrotic syndrome. But sometimes other glomerular diseases like membranous nephropathy, membranoproliferative glomerulonephritis, especially in older children, may also present as nephrotic syndrome. But they would often have some nephritic features like hematuria, hypertension, raised creatinine, but occasionally they can present as pure nephrotics. Now, there are many medications. There are no proven therapy for steroid-resistant nephrotic syndrome. So there's considerable diversity in the use of immunosuppressive drugs, and management is a therapeutic challenge. The 4 drugs available commonly to us for a steroid resistant is cyclosporin or tacrolimus. Say both are calcineurin inhibitors, cyclophosphamide and rituximab. In the background of steroid resistance, the drugs that have found to be giving a better response are the calcineurin inhibitors. So as opposed to those who were steroid responsive, where we had a different choice as first choice, here the first choice would be cyclosporin or tacrolimus, depending on the clinical choice. As the first choice, they show the best response. And you may need supportive therapy here, because it may respond, it may not respond, it may take time to respond. Child may remain edematous at this time. So if the edema is severe, you may need diuretics, because here you're not expecting rapid diuresis. So you base it roughly on if the weight gain is more than 7 to 10%, you can give furosemide. The dose should be a little significant dose. It's 1 to 2 mg per kg per dose. So not a very small dose, it won't act. Very important, avoid furosemide if there's hypovolemia, vomiting, diarrhea, or prior use of diuretics for a long time, then hold the diuretics for some time because the child may be hypovolemic. ACE inhibitors should be used in this situation because they have both an antiproteinuric effect and a renoprotective effect. So all steroid-resistant nephrotic syndrome should receive ACE inhibitors. It can be started in low doses and step to higher doses to support the clearance of proteinuria. The careful use of monitoring when you have ACE inhibitors is important because ACE inhibitors, if there is also some renal impairment, can cause hyperkalemia. So things which have very high potassium, like coconut water, which is very common in our population to use as a cure for oliguria, should be avoided. So little potassium-rich food should be avoided. Second, in the presence of a hypovolemic insult, like diarrhea, vomiting, or child is very unwell, taking very poorly orally, you should withhold ACE inhibitors because otherwise the child will land up with you with an AKI. Statins doesn't come out very strongly as a recommendation for pediatric age group. Definitely not for steroid-sensitive nephrotic syndrome. But in steroid-resistant nephrotic syndrome, there's persistent dyslipidemia, which is a risk factor for cardiovascular disease. So there are defined levels at which if we have lipid abnormalities for more than 6 months, you first try dietary changes, and if that does not help, you may add statins in this. Usual starting dose of cyclosporin is 4 mg per kg per day in 2 divided doses. It has to be strictly 12 hourly, not just a BT dose. Initially, you may continue alternate day prednisolone, you give enalapril, furosemide, calcium, vitamin D, dietary advice. And in this particular child, the urine albumin decreased 1 month later, was not edematous, only mildly. Creatinine remained normal, which is something you need to monitor when you're giving calcineurin inhibitors because they are in themselves nephrotoxic. And we did the cyclosporin trough levels, which was within the expected range of 80 to 120 nanograms per ml. So this child was lucky. By 6 months, the child went into complete remission. This doesn't happen for all children. Cyclosporin was therefore continued and prednisolone tapered. And at 2 years, the child is in complete remission on a lower dose of cyclosporin, of steroids, of statins, normal cholesterol. Now, the biggest challenge comes for the pediatric nephrologist is whether they should omit cyclosporin or continue cyclosporin, because there is a big chance of relapse after omission of cyclosporin, which may be a difficult to control relapse. But we cannot keep continuing because normal creatinine does not exclude nephrotoxicity. So this is a difficult decision which the nephrologist has to make on each child separately. And in the event they decide to continue, a renal biopsy is important. If there is a cyclosporin which has been used for more than 2 years, or any marginal rise in serum creatinine. Risk of nephrotoxicity with the normal dose is about 9%, but you may develop resistance to cyclosporin also over time. There's risk of severe relapse after omission, and you may need to maintain optimal levels to maintain your response. And sometimes if you have hyperlipidemia of significant degree, you may have to give higher doses. So how long to continue? Usual cutoff is 2 years, but after that, what you should do is a question mark. Repeat biopsy in some cases, and the cost and compliance I would put, because now the cost is not that bad, so compliance is an issue. So finally, we need to minimize morbidity, edema, growth failure, infections, thromboembolic complications, dyslipidemias, malnutrition, drug toxicities, and what I would put as immunological abuse, because in a non-responding patient, there is no point adding more and more immunosuppressive drugs and continuing. Definitely, one should have a goal. What you would use, one should look at literature to see what is usable and has shown response and use accordingly. Last slide is about genetic forms of nephrotic syndrome, mostly focal segmental glomerulosclerosis. Often these have an early onset. Sometimes they may be familial because they may have an autosomal recessive or dominant transmission. They're usually steroid resistant, and even without a family history, about 30% of steroid resistant nephrotic syndrome may have a genetic etiology. So steroid resistant nephrotic syndrome today requires both a renal biopsy as well as a genetic study. And what is the importance of doing it? We know that this child will be resistant to all other immunosuppressive. So we can save them from unnecessary immunosuppression. Just because we have many now, we tend to give all of those sequentially to these children. So you can avoid that immunosuppressive medications. And you also know that these children have 100% progression to end-stage kidney disease. So the parents need to be counseled and prepared. Important thing is the outcome after transplant is good, because the disease does not recur post-transplant in a genetic case, whereas in the non-genetic varieties of FSGS, there's a 30 to 40% of disease recurrence. So I'll end with this, that it's a complex and a long road with nephrotic syndrome, and you may encounter many of what I've said on the way or even more. And so you would need to see carefully. And I would conclude by saying that pediatric nephrologists should be part of the journey always, especially when you start seeing that they are frequently relapsing, they are steroid dependent, or they are steroid resistant, they need a biopsy, they are getting life-threatening complications, and so that we have a limited choice of drugs in nephrotic syndrome. Which one to use safely for this child at this age, how long they should be tried, how should they be followed, all this would need the guidance of a pediatric nephrologist. So nephrotic syndrome, we work together in the management of these children. Thank you.
Thank you, ma'am. Thank you for the wonderful presentation. I think most of the questions have been so clear after your talk, and especially managing a child who is FRNS or SDNS. Yes, definitely it's a shared care. We would request Dr. Amit sir, since we are running very short of time, can we have your expert comments, and if you can take the questions also?
Yeah, thank you, ma'am, for the wonderful lecture. It has been pleasure listening you after such a long time. So one delegate has asked that whether SDNS, what is the role of MMF, cyclophosphamide or MMF, which is better? So there's no head-to-head trials as such between the cyclophosphamide or MMF. So cyclophosphamide we do not prefer in very young kid or a very older kid. So there is a very limited window of giving a cyclophosphamide somewhere around 7 to 10 years of age, just before the puberty, and its dose is also limited. And MMF can be given on either side of it when the child is too young to be exposed to cyclophosphamide or too old to expose to a cyclophosphamide. So it's not about being better, it's about the right choice at the right time and the right dose and duration. So, and the other person has asked what is the dose of levamisole and duration. So request all the pediatricians here that once the child is either frequently relapsing or steroid dependent, please refer it to a pediatric nephrologist to start the second line agents with the dose and duration. And then you can keep on seeing them as a pediatrician, like all cough, cold, fever, vaccination, all the things. And it's all just like Dr. Neha said, it's a shared care. It's never that uh, either a pediatric nephrologist can manage or a pediatrician can manage. It has to be both, because the second line agents have different side effects and different profile patients, and the choice of a agent depends on age, the steroid toxicity, the steroid threshold, the course the child had, and what kind of age it is. So all these things do give us an idea that what management to use. Suppose if a child is steroid dependent and have a very Cushingoid feature and developed a life-threatening pneumonia with pneumococcus, then I would preferably start for a 6 month, 7 or a 1 year course of a CNI first, so that we can take off the steroid, provide the relapses, and then take it to some other drug. There is no guideline that one is better than the other. It's about what age and what is the course of child is having. So I think this usually summarizes all of the questions except one, which is hypovolemia. So every hypovolemia, whether it's in a nephrotic child or it's in another child, has to be managed in a same way. Fluids first. It does not mean that when the child is edematous, you don't need to give fluids. If the child is hypovolemic, is in shock, then obviously you have to give the NS bolus first. Once the child starts passing urine after the bolus, then you can push the albumin and diuretics, but not diuretics at first.
There's one more question. Why not give importance to glucose monitoring or RBS in patients on steroids for 3 months as monitoring of blood pressure?
So, because child has a better insulin tolerance rather than intolerance or insulin resistance, so we usually do not check RBS uh, regularly. But yes, when the child is on CNI and steroids for some reason, then we do ask them to get an HbA1c every 6 months or so. So initially for just 3 months, no need, because child usually do not. And once you see on a daily urine protein sticks, if the child is having a high glucose, you will see the glucose there as well. So you are actually monitoring the high glucose levels in a urine on a daily basis once you are doing a urine dipstick testing.
I think I will pass it on to Dr. Ajay sir and Dr. Dinesh sir. And
Yes,
comments from our chairperson.
thank you, Dr. Neha. Dr. Ajay is here?
Sir.
I think Sir is there. So wonderful presentation by Dr. Uma ma'am, and lots of concepts are now clear in nephrotic syndrome uh, from general pediatric point of view. Say. Any comment from Dr. Amit sir?
So, sir, everything has been covered, and
Yes.
ma'am has presented in such a way that
Yes.
how to start with, how to follow the child, how the anthropometry is important, how the BP is important, when to do a biopsy, when not to do a biopsy. So I think everything is covered here. There
Yes.
will always be a little queries. We are always available to answer all those queries. So overall, it's a very enlightening to hear Dr. Uma Ali ma'am, and I'm thankful to have an expert, being an expert on his on our
Great.
lecture. Thank you, ma'am.
Okay. Sir, comment from Dr. Pankaj, sir, our past president, sir. Dr. Pankaj, are you there? I think so. Dr. Puneet, sir.
Thank you very much. It was a wonderful presentation by both the experts. And I would like Dr. Amit or Dr. Uma ma'am to say a few words about how to vaccinate such children. We know that you have covered the pneumococcal and inactivated vaccine can be safely be given, and other vaccines when child in remission. Can you touch upon a little bit on that also?
Yes, sir. So every drug has a different time point when the live vaccines can be given. You can give all the killed vaccines safely once the child is either off steroids or on a low dose alternate day steroids. So killed vaccines can be given. If the child was on a high dose steroids, like a first episode, then we preferably wait for 4 weeks. Live vaccines and killed vaccines both. Once the child is an infrequent relapser, you can give the killed vaccines and live vaccines as soon as you stop the steroids. Then you can give after 4 weeks of levamisole, after 4 weeks of mycophenolate mofetil, 3 months after cyclophosphamide, then 6 months after rituximab, and 1 month after CNI. So every drug has a different time frame when the live vaccines can be given. Killed vaccines can be given on when the child is alone on this immunosuppressive agents, especially on low dose steroids, or alone like cyclosporin or something like that.
Thank you. Thank you very much.
Thank you, Dr. Amit. Wonderful. And thank you, Dr. Puneet, sir. Now, pass on to Dr. Ravinder, sir, the Treasurer cum Secretary elect, to say vote of thanks, sir. Dr. Ravinder, are you there?
Yes,
Dr.
thank you.
Yes.
Thank you, Dr. Dinesh. Thank you, all the speakers, faculty, Dr. Umali. Thank you, Dr. Neha and Dr. Amit. I think nephrotic syndrome, pediatricians see usually because they are the first physician who encounter this case and they make a diagnosis and they refer to the pediatric nephrologist. So thank you, Dr. Uma ma'am, for clearing many doubts to how to approach as a first care of physician. Because most of the times they will not be obviously directly going to the pediatric nephrologist. So thank you all, and I think all the queries of the delegates have been answered. I think Dr. Neha just wanted to say something. Yes, Dr. Neha.
Sir, I would like to thank Dr. Uma ma'am because at last minute Dr. Uma ma'am agreed for our being a presenter, and I think it was such a lucid presentation. It was like a story for all of us. And thank you to Dr. Amit also for joining us as an expert at such a short notice. And thank you to IAP Delhi and to you for always being there. Thank you, sir.
Okay, thank you, Dr. Neha, thank you all. Over to Dr. Dinesh. I think time to wind up now.
Yes.
Thank you, sir. Thank you so much.
Thank
Good
you.
day.
Thank you.
Enjoy your day.
Thank you, everyone.
Thank you.
Yeah. Thank you all.
Thank you, ma'am.